The chapter under examination discusses the challenges of the revised opt-out system and the secondary use of health data in England. The UK government has established the care.data programme in 2013, aiming to build a central nationwide database for research and policy planning. However, the processing of personal data was planned without proper public engagement, leading to concerns about data protection and privacy. In May 2018, the government launched the National Data Opt-out (ND Opt-out) system, which is designed to regain public trust. However, there are no significant changes in the ND opt-out compared to the previous opt-out system, neither in the use of secondary data nor in the choices that patients can make. The only noticeable difference seems to be in the way these options are communicated and framed to the patients. The chapter also explores the behavioral law and economics literature, particularly the nudge theory, which suggests that default rules are very powerful because people tend to stick to the default choices made readily available to them. The crucial question analyzed in this chapter is whether it is desirable for the UK government to stop promoting the Type 1 opt-outs, and whether this could be seen as a kind of hard paternalism. The subject of this chapter is the secondary use of health data in England, which is one way of reaching these goals. The secondary use of health data refers to the processing of data collected during direct care for new purposes, such as research and policy planning. The chapter is divided into 7 sections, including an introduction, explanations of the main tenets of behavioral law and economics, nudging techniques in the healthcare sector, the National Health Service, NHS, and the opt-out system in England, some statistics on opt-outs based on recent data released by the NHS, and a conclusion. In conclusion, the chapter examines the challenges of the revised opt-out system and the secondary use of health data in England, focusing on the behavioral law and economics literature, particularly the nudge theory. It highlights the importance of understanding the psychological traits of human behavior and a variety of other factors such as emotional, social, and cognitive as the overarching framework to discuss legal issues. Section 6 delves into the theoretical discourse of libertarian paternalism in Cass Sunstein's narrative. Sunstein distinguishes between hard and soft paternalism, advocating for the latter, which provides freedom of choice. Behavioral law and economics, popularized by Richard Thaler and Cass Sunstein, postulates that improved choices and information disclosure can softly nudge individuals to improve decision-making and welfare. Examples of nudges include urinals with images of a fly to reduce spillage and cafeteria managers arranging food to encourage healthier options. Empirical studies at 2 college campuses showed that removing trays reduced food and beverage waste by 3,050%, saving 2 tons of food and 424 liters of liquid waste weekly. A choice architect is any person who changes small features in the environment that attract attention and influence decisions. A nudge is any aspect of the choice architecture that alters people's behavior in a predictable way without forbidding any options or significantly changing their economic incentives. The Global Positioning System, GPS, is a canonical example of a nudge, as it helps individuals find the best route without coercing them to take one particular route. Nudging is not new. The private sector has been using different nudging techniques for decades. However, some nudges may be regarded as more controversial than others, such as road signs that can be dangerous if placed incorrectly. Choice architects have the responsibility of organizing the context in which people make decisions. Default rules are powerful nudges, inevitable and everywhere. An example is the hardware and software of printer machines, where users can choose between single or double-sided printing. Single-side printing would be the default option, encouraging users to choose double-sided printing to save paper. This chapter focuses on default rules as prime nudges, illustrating how they can be used to influence behavior in a predictable way without limiting individual freedom. Here is a combined summary of pages 5 and 6 of the research paper. Research has shown that small changes in design features, such as default settings, can significantly impact behavior and conservation efforts. For instance, Rutgers University's switch to double-sided printing saved over 89 million sheets of paper, equivalent to a 44% reduction or 4,650 trees. This zero-cost option demonstrates the potential of subtle design changes in making a substantial environmental impact. In the healthcare sector, behavioral economics insights have been applied to organ donation, where opt-out systems have led to significantly higher donation rates compared to opt-in systems. For example, countries like Spain, Austria, and France have implemented opt-out systems, resulting in exponential increases in organ donation rates, whereas countries like Denmark and the Netherlands, with opt-in systems, have much lower rates. Empirical studies suggest that cultural and social factors influence decision-making in these systems, with opt-out systems being viewed as more virtuous and opt-in systems being seen as more egotistic. In the context of public health, behavioral economics can be applied to cancer screening. A recent blog by surgeon Ara Darzi highlights the potential of linking cancer screening to familiar tests, such as dental checkups or annual vehicle testing, to increase participation. This approach leverages the power of nudging and default rules to improve healthcare outcomes. In England, the National Health Service, NHS, provides universal and free public health services, generating a vast resource of primary and secondary healthcare data. This data is protected by the common law duty of confidentiality, but exceptions exist for special cases, such as court orders or overriding public interest. The care.data program, initiated in 2013, aimed to extract patient information without consent to build a central database for research and policy planning. However, the program was criticized for lacking proper public engagement, and its central database was intended for use by both public and private entities. The National Data Guardian, NDG, has developed models for consent and opt-out for the care.data program in England. Following public concerns, the government paused the care.data program, leading to the Caldecott review, and ultimately its cancellation. A new National Data Opt-out, ND opt-out, system was introduced in 2018. The purpose of this system is to facilitate the secondary use of confidential health data without explicit consent while respecting patients' autonomy. However, opt-outs can pose challenges to data integrity, and nudging techniques may be employed to minimize this risk. The UK government has emphasized the value of secondary health data use for research and policy planning, but public dissatisfaction with certain deals, such as the Google DeepMind collaboration, has raised concerns about sensitive data processing for new purposes. The Google DeepMind deal allowed the company to access health data from over 1.6 million patients to develop an app monitoring kidney disease, but it was found to have failed to comply with data protection law. The ND opt-out system replaced the previous Type 1 and Type 2 opt-out system, which allowed citizens to prevent the secondary use of their confidential information. The Type 1 opt-out prevented information sharing outside GP practices, while the Type 2 opt-out prevented information sharing outside NHS Digital. The Type 2 opt-out was replaced by the ND opt-out in May 2018, and the Type 1 opt-out is no longer communicated as an option. The Type 1 decisions will be removed in 2020. Figure 1 illustrates the old opt-out system in England. Despite the introduction of the new ND opt-out system, research suggests that there has been no significant change in the secondary use of health data, nor in the choices available to patients. The primary difference lies in how these options are communicated to patients. Limitations and concerns regarding the opt-out system and data protection remain, highlighting the need for ongoing evaluation and improvement. The Type 1 opt-out is the only option that truly stops data from being shared outside direct care, as shown in Figure 1. The Type 2 option had several unclear limitations, including the exemption of pseudonymized data for secondary purposes regardless of patient choice. The goal was to reduce healthcare costs and improve the system's effectiveness, thus nudging patients toward the Type 2 opt-out, which had a public interest. From May 2018, the Type 2 opt-out has been replaced by the ND opt-out, with existing Type 2 opt-outs automatically converted to ND opt-outs. The government stopped promoting Type 1 opt-outs for citizens, and the Type 1 opt-out is not publicized on publicly available materials. It can only be found on the NHS website under Resources for Health and Care Staff. The new ND opt-out will only apply when identifiable data is shared for research and managing the healthcare system efficiently. Thus, in the case of anonymized and pseudonymized data, this choice does not apply. However, the use of the terms anonymized, pseudonymized, and de-identified is not consistent in UK legal terminology, which might confuse citizens about their meaning. In this chapter, the terms anonymization and pseudonymization are used consistently with the GDPR and the EU Data Protection Board. Anonymized data can no longer lead to the identification of the data subject, while pseudonymization reduces the linkability of a dataset with the original data subject. The concept of direct care is broader than assumed, including the assurance of safe and high-quality care, which requires background work that might not be apparent to patients. The presentation of information on patient information materials might lead to misunderstandings due to inconsistent terminology and unclear limitations of the opt-out options. The National Health Service, NHS, utilizes various information materials to communicate the secondary use of health data to citizens, emphasizing its importance for research and policy planning. These materials, including leaflets, posters, and online content, primarily focus on the value of health information, stating that it helps to improve your individual care, speed up diagnosis, plan your local services, and research new treatments. However, the presentation of this information may lead patients to assume that opting out is not necessary, as the materials do not explicitly convey the potential risks and consequences of data sharing. The NHS materials also claim that strict rules about how this data can and cannot be used were strengthened in May 2018, but this statement is debatable, as exemptions to the opt-out system remain unchanged. Additionally, the materials assure patients that the NHS is committed to keeping patient information safe and always being clear about how it is used, despite previous instances of confidential patient data being shared with private companies, such as Google DeepMind, without proper legal basis. The leaflet defines confidential patient information as information that identifies you and says something about your health, care, or treatment, but notes that information that only identifies patients, such as name and address, is not considered confidential and may still be used for administrative purposes. The materials also outline the potential users of confidential patient information, including NHS, local authorities, universities, and pharmaceutical companies, but fail to mention non-medical companies that may also access health data. The information materials introduce exemptions to the opt-out system, including situations of high public interest, such as epidemics, but do not provide comprehensive information on other exemptions, such as court orders and the use of de-identified data. Patients are assured that choosing to opt out will not affect their individual care, as confidential patient information will still be used for direct care regardless of the opt-out decision. However, this information may also lead patients to assume that their data will be used regardless of their choice. The National Health Service, NHS, employs various strategies to inform citizens about the National Data Opt-out (ND Opt-out) system, which allows individuals to opt out of sharing their confidential patient information for research and planning purposes. A key nudging strategy is the provision of information materials, including leaflets and online resources, which aim to educate citizens about the opt-out system and the implications of their choices. However, research suggests that citizens often lack deep knowledge about how their information is processed, and reading through privacy policies can be burdensome. The NHS provides special information materials for minority groups and young people, which differ in design and wording from the general materials. These materials are approximately 450,500 words in length and have a similar structure, but the leaflet for young people has a shorter general word length, making it easier to understand. The materials for caregivers, such as doctors and nurses, advise them to promote the NHS website, which addresses concerns about privacy and data selling. The NHS regularly releases statistics on opt-outs, which show that the number of Type 2 opt-outs was 1.4 million in March 2018, representing 2.42% of the population. The number of ND opt-outs increased to 1.6 million in March 2019, representing 2.74% of the population of England. These numbers are relatively low, especially compared to the previous system. The Type 1 opt-out is no longer advertised to the public, and existing Type 1 opt-outs are planned to be removed in 2020. Table 1 compares the NHS information materials on the ND opt-out system, highlighting the similarities and differences in the materials provided for different groups. The materials contain similar information, but communicate the message in a slightly different way. Overall, the NHS's approach to informing citizens about the ND opt-out system is multifaceted, but the effectiveness of these strategies in promoting informed decision-making remains to be evaluated. The research presents opt-out rates in England, specifically focusing on Type 1 and Type 2 opt-outs before May 2018, and the National Data Opt-outs, ND opt-outs, after May 2018. Figure 2 illustrates the opt-out rates, with Type 1 opt-outs reported at the GP level, resulting in potential duplications, whereas Type 2 opt-outs are accurate, with every opt-out choice registered and reported with identifiable patient information. The number of opt-outs remains relatively low, with only 0.3% of the population deciding not to share their personal data in the new system. Table 2 provides a comprehensive overview of the opt-out rates in England, with Type 2 opt-outs converted to ND opt-outs in May 2018. The ND opt-out rates slightly increased, potentially indicating the success of the NHS's campaign on the importance of sharing health data. The discussion shifts to the concept of paternalism in healthcare, particularly the notion of hard paternalism versus soft paternalism. Cass Sunstein's work, Why Nudge? The Politics of Libertarian Paternalism, is referenced, where he challenges John Stuart Mill's harm principle, which suggests that individuals can do whatever they want as long as their actions do not harm others. Sunstein argues that, in some cases, paternalistic interventions are desirable to provide means for improved decision-making. The four types of paternalism are categorized into hard and soft paternalism, differentiated by the imposition of material costs on individuals. Hard paternalism involves coercing people's free choice, whereas soft paternalism allows individuals to choose their actions with minimal state intervention. The latter is exemplified in the GPS example, where individuals are nudged to make informed decisions without coercion. In contrast, traditional, hard paternalism involves the state using its coercive power to nudge citizens to do what is in their best interests. The legitimacy of government intervention is contingent upon the individual's conscious awareness and voluntary actions. The bridge exception illustrates this point, where the government's use of force to prevent harm is justified when the individual is unaware of the risks. Sunstein argues that government intervention, nudging, and autonomy are not mutually exclusive, and that choice architectures can be designed to promote active decision-making. Libertarian paternalism, as advocated by Sunstein, encourages individuals to make informed choices, thereby addressing the limitations of a one-size-fits-all approach. The application of behavioral law and economics in policymaking has gained significance, with nudge theory being a valuable tool for improving the normative framework. The UK's new end opt-out system, however, raises concerns, as the limited choices provided may be seen as hard paternalism. The value of nudges lies in promoting choice, and a soft paternalism approach is advocated, which respects citizen freedom while promoting welfare gains. This approach is compatible with active choice mechanisms, nudges, and default rules. The importance of leaving an option to revisit decisions is emphasized, as individuals may feel frustrated by predetermined choices. The Type 1 opt-out system is recommended as a default rule, enabling patients with more options and offering a stronger data protection scheme without overriding individual freedom. This approach aligns with the principles of libertarian paternalism, promoting informed decision-making while respecting autonomy. The research is supported by grants from the Novo Nordisk Foundation and the Multidisciplinary Health Cloud Research Program. The references cited include works on behavioral economics, public responses to health data sharing, and the application of big data in health research. The discussion highlights the need for a nuanced approach to government intervention, one that balances individual freedom with the promotion of welfare gains. Title: Legal, ethical, and wider implications of suicide risk detection systems in social media platforms. The paper discusses the legal, ethical, and broader implications of implementing suicide risk detection systems on social media platforms. It highlights the importance of addressing these issues to ensure that such systems are not only effective but also respect user privacy and comply with relevant laws. The authors begin by discussing the ethical considerations surrounding the use of big data in healthcare, particularly in relation to patient consent and privacy. They argue that while big data has the potential to revolutionize healthcare, it is crucial to ensure that data collection and analysis are conducted in an ethical manner. The paper then delves into the legal framework governing health data, focusing on the General Data Protection Regulation, (GDPR), and its implications for data processing in the health sector. The authors emphasize the need for a balanced approach that respects individual privacy while allowing for the use of health data for research and public health purposes. In addition, the authors explore the concept of nudging in the context of health policy, drawing on insights from behavioral economics. They discuss how nudges can be used to influence people's behavior in predictable ways without limiting their freedom of choice, and highlight the potential benefits of using this approach in health policy. Furthermore, the paper examines the role of intermediaries in improving cloud architectures, particularly in the context of health data. The authors argue that intermediaries can play a crucial role in facilitating the secure and compliant processing of health data in cloud environments. Finally, the paper concludes by emphasizing the importance of addressing the legal, ethical, and broader implications of implementing suicide risk detection systems on social media platforms. The authors call for further research and discussion on these issues to ensure that such systems are developed and implemented in a manner that respects user privacy and complies with relevant laws. Here is the combined summary. This compilation of references spans multiple disciplines, including healthcare, artificial intelligence, law, and behavioral economics. The cited works explore the intersection of technology, policy, and human behavior, particularly in the context of healthcare data and its secondary use. The references highlight the growing importance of artificial intelligence in healthcare, the challenges of electronic health record data, and the need for robust frameworks governing the use of personal data for research purposes. The European Union's General Data Protection Regulation, GDPR, and its research exemption are specifically mentioned. The role of behavioral economics in shaping policy decisions is also emphasized, with a focus on nudging and opt-out strategies. The works of Thaler, Sunstein, and others are cited to illustrate the potential of behavioral economics in influencing individual choices and promoting public welfare. The compilation further explores the complexities of consent, trust, and public perceptions regarding the use of health data for research. It highlights the need for transparent and ethical approaches to data collection, storage, and analysis. The legal and regulatory frameworks surrounding healthcare data are also addressed, with references to various national and international initiatives. The tension between promoting innovation and protecting individual privacy is a recurring theme throughout the compilation. Ultimately, the references collectively underscore the importance of interdisciplinary collaboration and a nuanced understanding of the technical, ethical, and legal aspects of healthcare data management. By acknowledging the complexities of this domain, researchers and policymakers can work towards developing more effective and responsible strategies for harnessing the potential of healthcare data.